you to, okay, so now it's recording, and anyone who joins us will also get that same notice. So also again, welcome today. We encourage people to, I'm Jay Schwartz, I'm the Director of Helping a Jewish for Good. I'm here with my colleagues, Shoshana Funk, Stacey Abramowitz, and Jordana Brown. And so they can all wave. And yeah, we're just really glad to have you all here. For those of you, like I said, I encourage you to turn your cameras on just because it's nice for speakers to speak to faces, but if you're not comfortable, that is okay. Again, thank you all for joining us for this special program, made accessible and possible to us today by Jewish for Good, the Leon Levine Foundation, and Carolina Foundation for Jewish Seniors. Jewish for Good's Helping Department offers a comprehensive range of services that help people meet life's challenges. We deliver high quality professional social services for adults and their families through all stages of life. This includes counseling, case management, financial assistance, food pantry, and programs like this. Much of what we offer is free and all of it is open to everybody, Jewish or not. For more information, I invite you to visit our website, jewishforgood.org. And in the chat, I'm going to put, we also have on our website additional resources related to this talk today. So I will put that in the chat as well. I think I sent it when I sent the link, but I'll also put that in there as well so you can look at those afterwards too. So today we are, like I said, we invite you to ask questions if you'd like. Unmute yourself, put it in the chat. I'd be happy to ask them for you if you're not comfortable. But we are very lucky to have Dr. David Wohl here again to speak to our group. He spoke with us last year and everyone wanted him to come back, and we appreciate that out of your busy schedule that you took the time to do that. Dr. David Wohl is a professor of medicine in the Division of Infectious Diseases at UNC Chapel Hill. He completed his infectious diseases fellowship at UNC, his residency in internal medicine at Duke, and received his MD from Robert Wood Johnson Medical School in Camden, New Jersey. Dr. Wohl's research interests include serious viral infections, including HIV and viral hemorrhagic fevers, did I say that right? Such as Ebola and Lassa fever. He has been conducting HIV-related research for over 20 years, including studies of aging with HIV infection, as well as the nexus between mass incarceration and the HIV epidemic. As the site leader of the UNC HIV Prevention and Treatment Clinical Trials Unit at Chapel Hill, he oversees a large team conducting cutting-edge research on HIV therapeutics and prevention. Currently, he's been featured in a number of COVID-19 articles and interviews, and we welcome here today to talk about how the pandemic is becoming an endemic. So welcome, David Wohl. Dr. Wohl.
Thank you, Jenny. I'm going to try to share, but this always gets a little bit dicey. It doesn't look like it's liking it. So let's try. Allow Zoom, open system preferences. Okay, I think I got it. Hold on one second. But again, thank you. This is great to be here again. And I think I just have to give my system permission. Ooh. All right, hold on one second and I will be right back. It's going to want me to go right back on, so hold on.
Okay. And in the meantime, actually, I will put that link into the chat for the additional resources, because I think we have some good links related to this topic. And again, I will be putting this in the evaluation form I send out next week too. And we'll do that right now for y'all.
Yeah, let's try it now. The host has disabled participant screen sharing.
Oh, I just have to, now I have to, because you're a new participant, I forgot I have to get you up. So, I mean, I don't think we see you either. Oh, yeah, we didn't see your camera's not on quite yet.
Yeah.
And let me make you a co-host.
Yeah, he's here. He's here.
Yep, let me see it. Okay, and then I will make you a co-host. There you go.
Okay, let's give it one more try. There we go. Let's see if this works. Share screen. Yes. Awesome. That wasn't too bad. Okay, so let me minimize you guys. Let's maximize this. All right, well, thanks. I think this is great. And this is really an important topic. It's almost one of those things where no one gets sick of talking about, like, where are we, what's going on? There's new stuff coming out all the time. Certainly reading through recommendations that we hear from the CDC, even those of us who have degrees in medicine and epidemiology and public health don't understand it all, let alone anyone else. So I think talking about this helps me. And it also, I think, helps spread the word, because now after this, you're all deputized to talk to folks, whether it be, you know, at the dinner table or online, so that they can get set straight. about what's real and what's not real. So let's go through it. I'm not going to talk a lot about like a lot of data and a lot of slides. I just want to make sure there's some level setting that we all know where we're coming from. Again, because we're deluged with lots of information and sound bites. And I think it's just important to get like on the same page. So the good news is, and some of the best data, of course, regarding COVID-19 comes from places like the New York Times. And I'll tell you, I also am part of, on Twitter, I definitely get a lot of good information from experts who I follow. So New York Times has done a great job of tracking data from the CDC and other sources. So this is over the last 90 days. You can see that, January, February, we were in the thick of things and things have slowly gotten to this plateau. And you can see if you've got really sharp eyes that towards the right, there may be a little bit of an uphill, but it's still pretty level, just a little bit of a slope up. But good news is those are cases. And of course, that's an underestimate. Lots of people are getting tested at home. So the New York Times and the CDC and our local North Carolina Department of Health and Human Services don't get to know about every case, but just taking the temperature of what we do know from people getting tested at clinics and at health departments, there's been a little bit of an uptick, but hospitalization remains really low. Deaths have continued to plummet. And you can see the percent changes here. So we've got a lot more cases, but not a lot more hospitalizations and a decrease in people in the ICU and decrease in death, which is basically almost what you would want from a good vaccination campaign. We may not be able to prevent all infections, but it's showing us that the vaccines, and to some extent, as we'll talk about, natural infection, have combined to make us more impervious to getting really, really sick with COVID-19. And the vaccination rates, we can say, oh, well, wring our hands at just how unvaccinated we are. But when we look at this, we can see that at least one dose, which counts for something, 77% of people of all ages, even people not eligible, 77% have gotten at least one dose. 2/3 of us have gotten fully vaccinated. And then when we start talking about people who could get the vaccine, it gets even higher. And this is for the country. So we're not doing horribly. And people who are older, of course, are wiser. And almost all of those people have been fully vaccinated. So that's great news. So where are the cases? Again, this is an underestimate. It has to do with where testing is done, how people get tested. But in general, it's showing us where this latest wavelet of Omicron has hit us. And this is just recent data. So just over the last several days, we can see the Northeast has gotten hit hardest, and we'll focus on North Carolina, but we can see that right where we are right now also is a little bit higher than some other parts of the state. But in general, yellow is good, dark orange is not so good. So here's North Carolina data, and it looks a lot like what we saw for the country, right? So you see the slope down and then maybe a little bit of an uptick, but hospitalizations still are really low, lower so than what we're seeing in the country, because the country's getting influenced by other parts of the country that we're not experiencing the same thing. So increase in cases, lots of increase in cases, over fourfold 14-day change. So we're getting a lot more COVID. Certainly, I know of more and more people calling me saying, I got COVID, my family has COVID, but not getting sick enough to be in the hospital or the ICU or dying. These are all profoundly down. Again, and when we look at our numbers, vaccination numbers, they're, pretty good, about what we see for, the whole country. And as we'll talk about, there's some differences, but especially being fully vaccinated. But we've got a lot of people vaccinated. And then during Omicron, a lot of people who got Omicron, which isn't, of course, either one of them, foolproof protection from getting infected, but it helps. And again, looking more granularly at the data, this is all really good news. So COVID patients in ICUs, new reported cases per day, tests done by day, really good news. Okay. So who is getting hospitalized? When we look at who's getting hospitalized now, again, just like we've seen before, it's older people. So the dark blue line are people who are 70 plus. So that's always been the case, and it continues to be the case. So while we have very few people getting hospitalized, those people who are getting hospitalized are older, okay? Oftentimes unvaccinated, sometimes vaccinated. Rarely fully vaccinated and boosted, but it does happen. As we get older, our immune system doesn't work as well. We may not respond to the vaccines. So if someone basically has an immune system like somebody unvaccinated, they can have similar outcomes. So we could talk about that as well. Where are the hotspots in North Carolina? Well, according to the New York Times, Durham. So we can see that, and certainly out west near Asheville, there's an area where there's more cases. This is cases per 100,000 people. So we're not in the far right like those people are out west, but we're certainly having, relative to other places, more cases, okay? Again, this is per capita per 100,000 people. When we look at vaccinations, we can see that there's parts of our state that are doing really well, including where we are right now. And again, this is where we're seeing less hospitalization, less people getting sick. But in these pale colors, right here in the middle of the state and somewhere on some of the periphery out east, we can see that the percentage of residents who are fully vaccinated is quite low. And in general, not completely, but in general, those are places where we see the deaths per capita as being highest. So there's a correlation where we see more vaccination, we see less death. So one thing I want us to understand, really, really important, because this comes up all the time, is the CDC has come up with this idea that we can track community levels of COVID. And so they've come up with this indicator that we are using in our schools, that we're using in our workplaces to help us understand what we should do. This may guide our government when it decides about mandates or about masking policies. So the way it breaks down, and this, I wish I could make this simpler, but it's really hard. But the way it breaks down is the first part of the fork in the road of the algorithm is, are there fewer than 200 people per 100,000 on average in the last 7 days who've been diagnosed with COVID-19? Or is it more than 200 people? If you're less than 200 people per 100,000 in your population who've been diagnosed on average over the last 7 days, you're in a lower category than more. So where 200 came from, I have no idea. And then on top of that, if you're in that category, of having less than 200 people per 100,000 over the last week, then they look at admissions to the hospital and hospital beds. So if less than 10% of new COVID admissions, less than 10% of new admissions are COVID over the last 7 days, you're still in the low category. And if the percent of inpatient beds occupied by COVID patients on average over the last week is less than 10%, you stay in the low category. So if any of these three, if we have more than 10% of people being admitted to hospital are admitted for COVID, if more than 10% of your hospital beds at Duke or UNC are filled with people with COVID, or you have more than 200 people per 100,000 diagnosed with COVID in the last 100,000 people over the last 7 days, then you're no longer in the low category. Then you can move into the medium or even the high based upon if we're having a surge or not. So things they're looking at, number of cases that are reported, and the number of admissions that are COVID, and the number of hospital beds that are COVID. That gives you your general COVID community level. So where are we right now? Here's Durham. This is as of this morning. The number of cases per 100,000 people over the last 7 days on average is 100. So we're well below 200. Now, it was 70 about a week and a half ago, so it's gone up, but it's still less than that magical 200. What about new COVID admissions to the hospital? Less than 10%, but just barely. And then the number of beds, though, that are occupied by people with confirmed COVID-19, way below 10% in Durham. Okay, so it's 3.6%. That's why the CDC says Durham County, when we just look at general COVID-19 level, is low. But to make things more confusing, because they're worried we might understand that, they also talk about CDC community transmission level. So this is a transmission level. That's different than the burden of COVID on your community. This is how much of it is being spread. That's why it's a different number. And I had to find out how they calculated this by Googling, because I couldn't find it on the CDC website. And USA Today had a story about it that talks about how they calculated it, and it has to do with the testing. It all is about what tests are done, these PCR tests, not the rapid tests, and what proportion of those over the last 7 days are positive. And according to the CDC, even though we are in Durham County, a low COVID community level, criteria fitting, our transmission level is high. So we're a high transmission community in Durham County, and that's obviously around surrounding counties pretty similar, maybe a little bit less, but we are a high transmission. So there's lots of COVID being transmitted, but the burden on our systems vis-a-vis the hospital system still remains low. This drives many of us crazy because we have to make decisions about this. And we see this red county and we're like, whoa, how do we take off masks in school? And how do we, tell people to go back to restaurants and bars when there's so much transmission? And it's really driven by this. We've seen the positivity over the last 7 days has gone up. Again, this is Durham. And so you start seeing more and more testing and more positivity. And this is an underreport, again, because people are getting tests and they're doing it at home and they're not even reporting it, which they shouldn't. Okay, so what does that mean? It means that what we're seeing happen here in the United States and in North Carolina may be reflective of what's happening in some other parts of the world. This is a really nice graphic because it can show you different countries and what's happened since the beginning of this year as far as new cases. And we know that in places like Germany and the UK, there's been this massive uptick. So if we look at the United States, again, just like I showed you with the New York Times, it's been pretty flat. We haven't seen the upticks that other countries have. Whereas the United Kingdom, they definitely had an uptick over the last month or so, including in hospitalizations. We have not seen that. We've been more like Denmark, that got really hit hard by Omicron like we did, and then leveled out and hasn't seen an uptick really dramatically in bad things happening to people, even in their cases. Now they're even more vaccinated than we are. So I think the good news is it seems we're somewhere in between. We have more cases, just like the United Kingdom did, than Denmark saw, but we haven't had the hospitalizations so far that the United Kingdom had. And it could be for a variety of different reasons. We didn't just like shut off masking, the great mask escape, that started long ago. People all over the country have not been masking for a long time. And Omicron hit, and a lot of us got immunized, if you will, even though we didn't ask for it, from Omicron. So the current situation, as you know, is BA2, which is that flavor of Omicron. That's what we're getting infected with now. There may be some varieties of BA2 that you've read about. They basically look a lot like BA2, and that's what we have to think about. Some of the medicines used previously to treat COVID-19 don't work as well against BA2, but we still have medicines, and we'll talk about that. So far, so good about cases and hospitalization. BA2 does not cause more severe disease. It does not evade vaccine protection more than the original Omicron. So vaccines continue to work just as well today as they did basically a month or 2 months ago. And vaccine plus booster really seems to be making a big difference as far as hospitalization and dying from COVID-19. And as we said, vaccination continues to go up. And as we said, lots and lots of people are vaccinated. Now, they're not all boosted, and that does leave people vulnerable, I think, to getting infected and maybe not getting sick enough to be in the hospital, but getting sick enough to feel really crappy. And I think that's what we're seeing from a lot of unboosted people. We do know the vaccines work. If there's any among you who are skeptical about this, there are lots of data. This is just an example where vaccines have been shown very clearly to reduce cases and also reduce deaths. And the black line here is people unvaccinated, much higher than the people in the dotted blue line with primary series only, or the dark blue line, which is primary series plus 1 booster. So we know that this works. This is why we're so evangelical about it. So vaccines, what about the 4th dose or a second booster? Again, the terminology is confusing, but I like to say, how many shots have you had? Have you had 2? Have you had 3? Have you had 4? So the 4th dose of an mRNA vaccine, meaning Pfizer or Moderna, is now recommended for a lot of people. So people 50 and older, regardless of their immune status, could get a Pfizer or Moderna if it's been 4 months since the receipt of their first booster shot, which would generally be your 3rd shot previously, okay? If you're 18 and above and immunocompromised, then you could also get boosted, and that makes sense too. And those who are 12 years of age who are immunocompromised, also, if they can get a Pfizer vaccine as well, if it's been 4 months since their last booster. So boosting is happening. We could talk about the timing of boosting in our discussion, because I think we want to make sure that we boost strategically, given that there could be a surge in the summer like we've seen previously, or even in the winter. But I think there's individual cases we can talk about in the question and answer. But in general, I'm recommending most people get boosted now with a 4th dose, especially if it's been 6 months or more since your 3rd shot. So if you got Pfizer or Moderna, and then you got your booster last October or so, I think it's time now to think about getting your 4th shot. Again, I think it will protect you coming into the summer and maybe even into the winter, not only from infection, but certainly from getting really sick, especially as we go forward. If you are more recent in having your 3rd shot, and or you had COVID-19 since January 1st, then I'm not going to arm wrestle with you. Then I might say, well, okay, maybe you can wait. And maybe it could be, June that you get boosted to help protect you later on in the year. So it depends a little bit about your situation. If you're going to be traveling, if you're going to be around other people, if you're a school teacher, there's all sorts of things that factor in. For me, just to give you an example, I had my 2 Pfizers back in the very beginning. I was one of the first people to get vaccinated, got my booster last October, my first booster. I got boosted 3 weeks ago. I was going on an international trip. I have kids in the house. I didn't want to take a chance. I'm okay getting another shot later this year if there's another shot needed. So for me, it made sense to get another shot. What about vaccines for kids? Pfizer and Moderna both working on this. Boosters now for CDC recommended for all children 12 to 15 years of age and for immunocompromised 5 to 11. 3-dose data in children less than 6 years of age is still pending. We don't have that yet. We don't have enough information. Moderna has requested FDA authorization, or will soon request FDA authorization for children less than 6, based upon about a 40% reduction in disease in kids who got 2 doses. That's not great, 40%. So they're also working on some tweaks to their formulation and also their strategy. But just to surmise, there's definitely work being done to get littler kids vaccinated with vaccine that is effective and doesn't give them high fevers. It's complicated, and unfortunately, the vaccine schedule just gets more and more complicated, and I have to use cheat sheets like this as well. There's some really good websites. There's this one right here, and we'll make the slides available to everyone that kind of summarizes all this, but even this is a lot of information, and so really, really hard. They've made it extremely complicated, and I hope that it gets easier. But right now, if you're fully vaccinated, got a booster, think about getting a 4th shot. What about natural infection? If I was talking to you 6 months ago, I would have poo-pooed this a little bit and said, natural infection, we don't think it works that well. Maybe it works a little bit, probably not as good as vaccine. It turns out that natural infection may work. These are data that just came out the other day. This is pre-Omicron, so that's a big caveat. But they looked at thousands and thousands of people in a healthcare system who came in for COVID testing with symptoms who were unvaccinated. And they looked at people who tested positive versus people who tested negative. And the people who tested positive, when you follow them, they were much, much less likely to get COVID and get sick with COVID than the controls, who were people who came in, got tested and were negative and were followed. So these are all unvaccinated people. So very interesting, in unvaccinated people, infection seemed to protect these folks for months later in getting COVID and getting sick. So I think there is some benefit. Unfortunately, these people got, infected and hopefully won the COVID lottery in being able to be followed, because some of the people, when they get tested originally, could get really sick and could have died. But those who survived and were followed, their chance of getting sick and dying after that was much lower. So if you survive your COVID-19, don't have long COVID, which wasn't addressed in this, then you're in a better shape. I think vaccination is a safer way. Of course, it doesn't lead you into the hospital. It doesn't give you long COVID, and it could be just as beneficial. We don't know how long natural infection protection lasts. It's not a given that it's going to be forever, so we don't know. What about COVID-19 treatment? This is like one of the last things I'm going to talk about, and then we'll open up for questions. There is treatment. Unfortunately, as you may have heard, it's not being made available to people as easily as we'd like, and I think that a lot of people don't know about it. So this is really for people who are at risk for severe COVID-19, which sounds pretty restrictive, except when you look at the criteria. It's defined very broadly. So it includes anyone with a body mass index of 25 or above. So what does that mean? That means if you're 5'8" and you're 165 pounds, you qualify. And you could do the math or look at a calculator to see if you or someone you know qualifies. This is about 80% of Americans in this country have a BMI of 25 plus. So it's not that this is so restrictive. Most people who get COVID-19 and have symptoms qualify for treatment. And it includes people with many common conditions, even if you don't have a big BMI or an elevated BMI, such as things like cardiovascular disease or previous cancer or asthma or seizures. So why get COVID-19 treatment? The number one reason is it reduces the risk of hospitalization. All the studies, that was the outcome that was looked at. Does it reduce people from getting hospitalized and dying? It didn't look to see, does your sniffles get better? Didn't see if you return to work sooner. Those things sometimes we're seeing in some of these studies, but generally not. It really reduces the the risk of getting really sick. So what medications are we talking about? Well, they come in pill form and injected form right now. And the oral medicines include a medicine called Paxlovid and another medicine called molnupiravir. And the injected medicines is a monoclonal antibody called bebtelovimab. So Paxlovid is the go-to drug. If you get COVID-19 and you have symptoms and you're in the category of people who are eligible for treatment, this is the drug I would take. It's 3 pills twice a day, taken for 5 days. It prevents the virus from replicating. In studies, it had a 90% reduction in hospitalization rate. The problem is it interacts with lots of other medicines. So you have to make sure, and your pharmacist and your provider have to make sure that you're not on a medicine that this would interact with in a way that could be dangerous. And there's a long list of these medicines, but there's online trackers, there's a science to this where we can figure this out pretty quickly. So a lot of people could take this medicine, but a bunch of people can't. And for them, there is the injectable, the bebtelovimab. Now, this is more complicated because this requires an injection through an IV. It's just a push, 30 seconds, but you have to be in a place where they do it, and there's only a few places that do it, and they watch you for an hour. It's a monoclonal antibody. It too reduces the risk of hospitalization. So the Paxlovid, anyone can prescribe that. Any doctor or clinician can prescribe it to a local pharmacy. You pick it up if they have it, and there's places to check if they have it or not. And then you can get it and take it that same day. And I think that's great. The bebtelovimab, you have to find an infusion center, and that your doctor has to refer you to it. And that's a bottleneck. What about molnupiravir? It's also pills. It's 4 pills twice a day. In studies, it didn't work as well as the other stuff. So that's why it's sort of a backstop. It's 4 pills twice a day, as I said, taken for 5 days. It forces the virus to mutate and thus not replicate well. Doesn't interact with other medicines, but we're talking maybe here about a 40% reduction in hospitalization. So not really in the same ballpark as Paxlovid, but these are, and it's better than nothing. So if you can't get Paxlovid or you can't get an infusion of bebtelovimab, I would take molnupiravir in a heartbeat. And it could be, if used earlier, it would be even better than what we see in the clinical trials. What about getting back to life? What about now, going to movie theaters, dining indoors, meeting with friends? We all have to judge how we're feeling about, our risk. I showed you, the good news, bad news. The good news is people aren't in the hospital, in the ICU, anywhere near they were before. I'm down the hall from the ICU. There's very, very few people here right now with COVID-19. But I just showed you that there's loads of cases. We've had a 450% increase in cases in Durham County alone. So your chances of getting COVID-19 are actually not that low. So it just depends how much in the mood are you to get COVID-19, and can you handle it if you did? You're fully vaccinated, you're boosted up, you're healthy. Those are the things that go into your mind. And our layers of protection still are operative. And we just have to think about how much we want to depend upon all of them or some of them, because to get really sick and get infected with this, all the Swiss cheese holes have to line up, right? You were close enough to somebody, they were able to infect you and breathe on you because they didn't have a mask, or you didn't have a mask, or both of you didn't have a mask. You got infected, but your vaccine, did it protect you or not? Those are all the things that kind of come into play. So for me personally, given the case rates, I'm still being very cautious. I'll just tell you what I practice. That doesn't mean you should practice it. I understand people who are saying, you know what, I'm ready. I got my vaccines. I'm boosted. I'm going out to eat indoors. That I'm not judging you. That could be fine because your tolerance for getting COVID-19 is different than mine. I'm just not in the mood right now to get it. I'm a little busy. I don't want to be isolated for 5 days or longer, and I don't want to give it to anyone. So I'm masking in indoor places where there's other people around. Certainly on airplanes, trying to wear an N95. I'm a big believer in 2 masks. I think 2 masks can work really well, like a surgical mask plus a cloth mask together. And I'll show you those when, we could talk about it on video. But I do think that this works really well. But an N95 works really well too. Certainly on a plane. It's okay if everyone else is not masking and you have a mask on. That's still much better than nothing. That works. So don't worry that, it's going to be for naught. it does work, but you want a well-fitting mask without those gaps. So I'm going to open it up now. I talked longer than I thought, but we'll open up for questions and try to handle anything that's on the chat. And I'm going to stop sharing.
Yeah, so there were some questions in the chat. I'm going to start with those and then we can open it to other people.
Super.
Someone's asked, you may cover this question in the talk, but here's the question. Now that the mask mandate seems to have been rescinded from planes, trains, and buses, what is your recommendation for people over 65 who may want to begin to fly again? This person's been planning to fly in June, but now feels it may be too risky to even do so, even though they're vaccinated and boosted.
Look, I think this is going to be a personal decision for everyone. And it really has to do with your risk tolerance and what you get joy out of life. Like if we want a quality of life. And I think that for many people, traveling to see family, traveling for an event, those are really important. I had somebody who is pretty immunocompromised contact me, a former professor. He's older. He was going to go to London for a meeting. Turned out it wasn't that important a meeting. Turned out, it wasn't going to be crucial. He could do it remote. We talked about it. He canceled the trip because it really wasn't worth it. Now, if it was like his grandbaby was being born and he was going to then the calculus changes. So you have to just, put your risk in perspective and take the measures, but not only did he have a risk because cases are going up, but he also, if he got infected, would potentially get really, really sick. But I'm in a different, so I went to Africa last week, right? I had to for work. I wanted to for work. It was hard, 24 hours of traveling with masks on and not, eating on the plane and all that sort of stuff. It was tough. Being around coworkers, including who I lived with a mask on constantly, playing Scrabble with my mask on at night. This is what we did, not eating indoors with them. Those are the measures you have to take if you really don't want to get infected. But other people say, you know what? The risk is low. I'm going to take my chances. So each one of us, if you're really worried about this, but a balanced worry, really understanding your own personal risks and the likelihood, again, that you're not going to end up in the hospital, you're not going to end up in an ICU if you're fully vaccinated and you don't have a severely immunocompromising condition, then I think, make your personal choices. So I don't know that there's one answer for everyone.
Thank you. So another question, I have a few in the chat. If someone else wants to jump in, they can. But what about the vaccination they say may come out of them that's improved for variants? Is this coming out? Is it worth waiting for?
Not worth waiting for. So there are studies going on. We're participating in this where we're looking at variant-specific vaccines. The one really amazing thing about the vaccine, so this is sort of just putting things in perspective. The Pfizer vaccine, the Moderna vaccine, the J&J vaccine. Remember, these were all developed for an ancestral strain of the virus that is now extinct. It's amazing. That virus that was circulating back in the beginning of 2020, it's not here anymore. You can't find it. But the vaccines were all developed against it. Yet, even though the virus has evolved through all these variants, these vaccines have kind of gone toe to toe. They've not become obsolete. Now, they don't provide 95% protection against symptomatic disease. It's lower, right? Because that makes sense. The virus has evolved. It's more like 70-something%, but still dramatic protection against getting really sick. So there's a commonality across all these different variants that the vaccines can still protect us against. So that's wonderful. When you look at the Israeli data, so in Israel, as I think most people know, they're following basically everyone in the country because they have data on them. They only use the Pfizer vaccine. And they found that people who had 3 doses versus people who had 4 doses, the 3-dose people compared to the 4-dose people, they were more likely to get infected for a while after 3 doses than the 4 doses. 4 doses protected you from infection for a few weeks, but continued to protect you against getting really sick. So these vaccines are doing what exactly we need them to do. Look, if COVID-19, and I'm not saying this is what's happening, but if COVID-19 basically just makes you feel really crappy for a few days, and some people it just gives the sniffles to, and very rarely ends you up in the hospital, we don't need all this crazy, we don't need all these mandates, we don't need all these restrictions, because flu does worse, right? Flu lands people in the hospital. Flu kills pregnant women. I mean, we see tens of thousands of cases. We don't even know how many because it's hard to count. But if we make it more like flu, then we don't need this pandemic crazy response. So I think the vaccines are working really well. And even Pfizer and Moderna now against these variants. So we may need to develop, look, this is like the iPhone 1 of vaccines. We've got a long way to go. There's going to be better vaccines. This is just the beginning. This is the prototype. This was our first shot. We're going to make better vaccines that work probably against other targets that were not, all the vaccines work against the spike protein. Well, the spike protein keeps changing. That's why it's a game of whack-a-mole. But there's parts inside the virus that don't change. That would be really hard for the virus to change. We're going to make better vaccines.
Okay, great, thanks. This question kind of goes along with that. It says, a pharmacist told me that the goal is to have 5 boosters in preparation for annual COVID-19 vaccinations, like flu and pneumonia. Can you talk about whether this may be a future next step in managing the pandemic or help us transition to an endemic?
I think that my prediction will be that probably about every year we will be getting some sort of COVID-19 shot. It may be that you get a foundation with the kind of vaccines we have now, like most of us have, and then we get a variant specific or some other booster. I've been not impressed yet with variant specific vaccines just because our general vaccines still continue to work. What we want is that protection to last longer. Remember, protection is twofold. Protection from infection. So when someone says the vaccines protect you or they don't protect you, you have to say, what do you mean? Protect you from infection or protect you from getting deathly ill? Those are the two, there's a distinction there, right? If I had to choose either one of those that I really want the vaccine to be really bulletproof with, it's protect me from getting on life support. I don't want to get on life support. I don't want to be hospitalized. It'd be great if you protect me from infection because then, nothing bad downstream. But we don't have that yet. We don't have a vaccine that's 100% like bulletproof. You're like wearing a force field. And that's going to be very hard to get, as we've seen from flu shots, right? It's very hard to do that. But even if you get infected, that you don't get sick, that's a huge benefit. Again, because the reason we freak out with this pandemic is because this is a lethal virus that ends putting people in the hospital. And then there's the whole long COVID thing, which again, I think is really important and we don't understand. We don't want people to get long COVID. And vaccination prevents you from getting infected and looks like it reduces you from getting long COVID. So yeah, I think we're gonna get a shot probably about every year.
Thank you. There's 2 more questions in the chat, but Marjorie has raised her hand, so I'll let her jump in.
Oh, yes. Thank you so much for this great talk. I'm curious if you consider a previous cancer as like 15 years ago, which is my case, an example of being immunocompromised.
Yeah, it would not necessarily be immunocompromised to the point that we feel you would be more likely to do poorly with the virus or not respond to the vaccine. Mm-hmm. And I know it's going to sound somewhat heretical, but I think in cases that are a little bit more ambivalent, where people are really worried about whether or not they mounted a response to the vaccine, one could check antibody levels. Now, a lot of doctors don't like to do it because it's hard to interpret. And remember, it's only one moment in time. That doesn't mean 2 months later, your antibody levels are still there. In some cases, I do it. I didn't mention it, but there is a medicine called Evusheld, which is another monoclonal antibody that could be given to people who are more immunocompromised than you are, and who aren't expected to mount a good response to the vaccines. And that antibody circulates in your body for a few months. And so that's something we do for people who we really know are unlikely to mount a response to the vaccine. But I've been surprised at how many people who are immunocompromised, when I check their levels, have sky high levels of antibodies. So it's very hard to predict.
Okay, thank you.
You're welcome.
So this next question from the chat goes along with that. It says, are there plans to get to a place where antibody levels are tested to know if another vaccination is necessary or when the next vaccination would be needed?
Yeah, it's a good question. And again, I think that most of my colleagues are a little bit hesitant to check vaccine levels. For one thing, if it's really high, the vaccine level from that lab, like a good lab like Quest or LabCorp, that tells you something. That's pretty good. If they're like absent, that tells you something. It's the middle that we don't know how to interpret. When it's in the middle, I don't know if that's enough or not. So, my son's in a study. He's on immunosuppressing medicine for his Crohn's disease. As part of the study, they check it, and I can tell you, so far so good. He's had 4 doses. His antibody levels are really sky high. If they were in the middle, I wouldn't know, and his doctors wouldn't know what it means. So I use it cautiously, for people who, might be a candidate for that Evusheld. I sometimes do it for people who are really concerned about taking a booster and the timing of the booster. Had a patient, again, who's immunocompromised, who was hesitant to take the booster just yet. And I said, well, let's check your level, and it was sky high. So we're going to wait to get his booster. I think you do it if you're going to act on the test, but you have to interpret the test. I don't think it's a prerequisite for getting another shot or for getting, and again, it could change in a few months. As we saw with the Israeli data, your antibody levels can start falling pretty quickly, and then you can be vulnerable to infection. Now, there's the other part of your immune system, which is your cells. Your cells can gobble up germs like Pac-Man. Those seem to stay around a long time. Antibodies are only one part of our immune system. There's also the cellular army that vaccines, make as well. And we don't measure those. And I think that's what keeps us out of the hospital.
Thank you. Someone put, a friend has been struggling with COVID for 3 weeks, vaxxed and boosted. They're slowly getting better. We're scheduled to vacation together in 4 weeks. Will she be safe to travel with if she has a negative test?
Yes. And so once someone has a negative test, and I would say, even a negative rapid test, I start to feel more comfortable around them. The people can continue to shed the virus long-term, especially if they're immunocompromised. People on active cancer chemotherapy, people are on some of these immunological drugs for rheumatological conditions, people with low immune systems from like HIV, they can shed the virus for a prolonged period of time. But given the time course you're talking about, if that person had negative rapid tests, certainly if they had a negative, I wouldn't do a PCR because those can linger positive even if there's not an infectious virus. If they had a negative rapid test, yeah, I would feel comfortable around them.
Those are all the questions from the chat, so people can feel free to put more in the chat or unmute themselves or raise their hand.
I have a question. What exactly does endemic mean? With COVID, are we at the endemic stage? Is flu an endemic situation?
Yeah, it's a really good question. So I think when we're talking about COVID being endemic, we're talking about something that is pretty much always with us and not periodic, right? So it's not something that comes and goes. Like Ebola is an example of something that's not really endemic in humans, right? It pops up in humans and then it goes away and we don't find it. It's probably endemic in some animal species, but not people. Flu is a little weird because flu, a little bit different than COVID, but somewhat like COVID. Year to year, we're getting very different flu viruses. It's almost like a different virus. So that's why it's so hard to keep track of it, because it's recombinating, it's reassembling itself in different animals and then hitting us. So COVID is endemic. So it's very interesting to talk about things like endemic or herd immunity. We talked a lot about herd immunity in the beginning of the pandemic, and people were saying, are we going to achieve herd immunity? And people say, we're never going to achieve herd immunity. We have herd immunity. Like you could see it right now. This is why Duke and UNC and ECU and Wake Forest are not chock full of people with COVID, even though the cases are going up considerably. Even though Durham is a high transmission county, we're not seeing people in Durham Regional, in the hospital with COVID because we have herd immunity through vaccination and through infection. So it is endemic, and it's just a matter of understanding that this is a reality. As long as our emergency rooms and ICUs are not chock full of people, and as long as our long COVID clinics don't have long waiting lists, we will be okay with COVID. It'll become another coronavirus that we live with, just like other human coronaviruses. Other human coronaviruses, we have an advantage because when we're little, we get them, right? We get them when we're 2 and when we're 3 and when we're 4 and when we're 5. We get them over and over again, such that by the time you're an adult, you've already been immunized and boosted multiple times at school or from your siblings with these other coronaviruses, such that they're not a big problem. But they are sometimes, but usually they're not. I mean, the worst thing we get is usually a cold. That's what could happen here but it's going to take, a whole generation of people getting exposed and vaccinated. And we're going to all have a mixture of exposure and vaccination, exposure and vaccination.
Thank you.
Any other questions?
I have a question. Oh. does
Oh, no,
somebody-
go for your question.
Just about long COVID, like, is there any predictor or is it just random of who might get long COVID and who doesn't?
Yeah, it's a little bit hard. A lot of the data on long COVID is kind of complicated by, lack of a standard definition. And, researching this, I could tell you that some of the questionnaires that we use in surveys, they're not very specific. And it worries me a little bit that we may not be an exact science, but I think there are people who clearly have long COVID and when you see it. I think the things that we're seeing is that the more severe your initial COVID was, it seems to be that correlated with your risk of long COVID. So that kind of makes sense, but that doesn't mean that there aren't people who have mild cases of COVID who do have lingering symptoms. That does happen. But the more severe cases of COVID-19, I think that we're going to find more and more that vaccination protects you from long COVID, and early treatment, I bet you, will protect from long COVID. Our treatment right now for most people is given too late. I didn't mention it for the treatments, but they work best within 5 days. And I would say the sooner the better. A very frustrating problem right now is that during the State of the Union address, the president made very clear that we would have test to treat, that you can go into a pharmacy, get a rapid test, and if it's positive, get a prescription there for Paxlovid or molnupiravir. That is not happening right now, no matter where. Even if you go to the website, the government website that tells you all the CVS pharmacies and Walmarts and Walgreens that have test to treat, if you call them, they do not. So I'm very frustrated. And that means if you do not have a healthcare provider, you have no access to Paxlovid right now. And that's true for many, many people. There's just nowhere for them to go. So it's very frustrating to me that we don't have treatment available to people, because I think it would stop long COVID from being as big a problem, and it would keep people out of the hospital. And I do think if you start, Paxlovid or molnupiravir or get bebtelovimab injection, your second day of symptoms, I bet you get back to work quicker. I bet you your symptoms go away like Tamiflu. But we just don't have that experience because it takes too long for people to get therapy. And that's really, really, really frustrating to me. And while UNC can do a lot of things, it's like, do I have the energy to work with people here to really try to set up test to treat centers when that really should be something that others should be doing? We're trying, we'll do it. I mean, we're trying to make it for anyone who's a UNC health patient. Certainly they can get test to treat. Basically, we can mail medicines to anyone within, a 40-mile radius from our shared services pharmacy. So I'm trying to just get that word out there. If you have COVID and you are a UNC health patient, you immediately should contact your UNC health provider and say, I've just tested positive, call me in Paxlovid, and get it mailed to my house, later today or tomorrow, if you think that there's no problem with my other medicines. And if there is, then you should get me an infusion. And if you can't get that, get me molnupiravir at my local pharmacy or send it to my house. It's as simple as that, but people don't know to do this. There's no advertisements because, these are all bought by the government. So the companies can't make advertisements saying, here's Paxlovid, ask your doctor.
Thanks. Someone asked, would an exposure take the place of vaccination?
It's a really good question. I think that not necessarily exposure, but infection. So
Oh, yeah, that's understand. Sorry.
Yeah. So I think that somebody contacted me today, 2 people just this morning. They had 3 shots of Pfizer, then before the end of last year, then this January got COVID, Omicron. Should she get a booster now? And I was like, you could. There's nothing wrong with getting a booster now, but I could see waiting until maybe end of May, June to kind of get that bump that we saw in the Israeli data. You know, the Israeli data showed that risk of infection after your fourth shot for about 2 months looked pretty good and then started to go down. Protection from getting really sick continued. So I'm worried about a summer. We've seen it before. Delta popped up during the end of June. I'm a little worried about a summer variant, not only a winter surge. So if I didn't get my shot 3 weeks ago, I think I would have waited till around June 1st and gotten it. But yeah, if you had COVID in January, I think that counts as a booster that maybe helps you delay your fourth shot. But yes, I think infection counts. We just don't know how well it counts.
Someone asks, can you talk about the role that nutrition plays in strengthening our immune systems regarding COVID? For example, can you talk about the role of vitamin C, D, soured products such as yogurt, etc., fruits and vegetables? Do you have any advice on nutrition to strengthen the immune system?
Yeah, Val, you're going to be very disappointed in my response. So, we would love it. Nutrition is really important for general health. It becomes a little bit harder to see how it helps with specific things like this, like a virus that's evolved to infect healthy people, well-nourished people. So more of the things that we have, I don't know helps, and there's certainly no data to suggest, in fact, data that shows it doesn't help to use some of these supplements and things. So good nutrition is important. We should all practice what we need to maintain healthy lifestyles. But I don't think so. I am an HIV doctor. Believe me, for 30 years, I've heard people talk about what they can eat to, help them fight this virus. And you know what? It doesn't work. So there's just some things that the battle is just too great that this really comes down to something else. Now, severe deficiencies of different elements that we need for sure. But I don't think it's going to make a difference. That's not to say if you get sick, you shouldn't eat chicken soup. Chicken soup's great. You should eat chicken soup or a vegetarian version. But I don't think that there's going to be a major role. And the vitamin D story is really disappointing. People with low vitamin D, people with COVID have had low vitamin D levels, but that just shows you that people who have low vitamin D levels are people who are generally sicker. They have more comorbidities. They don't get out as much. Like there's an association there that confounds it. So I'm sure that there are people online and other folks who would vehemently counter what I said, but I would just ask them to show us the data.
Someone said, if not contacting your UNC doctor for treatment, what over-the-counter medicine could be used for infection?
It's really interesting because in helping design some of the trials that we're doing for COVID-19 therapeutics, one of the things I said is, we're testing this medicine to see if it drops the virus in the nose, prevents hospitalization. And we were very interested in seeing, does it resolve symptoms? And I said, okay, let's look and see if it resolves symptoms and gets people feeling better. But it's got to be like, how are we going to compare ourselves to Tylenol? Because Tylenol does a really good job. So I have to be honest with you, anyone who's had a reaction to the vaccines, and most of us have, like you take the shot and you feel really bad starting about 24 hours later, Tylenol is like magic. And I've heard a lot of people talk about it. So I think that's the medicine to use. Sometimes ibuprofen, I prefer the Tylenol, but if ibuprofen works better for you, but I would try Tylenol. Other than that, there's not a whole lot that you can do when you have COVID. I think, just symptomatic management, drinking fluids, getting a lot of rest, staying away from people. The spectrum of this infection is just so wild. It's just so wide. Some people get almost nothing, and some people are laid up in bed and like you heard, 3 weeks in bed. We've had some physicians who are young and healthy who've been really, really, really sick. But remember, some of your sickness is your immune system fighting this thing. So just like you got sick during your vaccine, you're just getting that, but in a really big way. And so it's your immune system fighting the virus. It's not the virus destroying parts of your body. So just recognize that there's a battle going on and you're winning, but that's what you're feeling.
Again, there's nothing in the chat, so if anyone wants to unmute or raise their hands, they can. Um, Somebody just sent me a message. They received a Moderna booster in November. Things have kept me from getting a second booster. Oh, and so this person says that they want to listen to you. That it may is it best just to wait until June to get the second dose then, or second booster? I mean,
February, March, April, May. Yeah, I mean, I think by 6 months, I'm a little hesitant to go beyond 6 months since your last booster, especially if you're going to be out in the world. Again, so I think people are generally protected pretty well for a few months from infection. All of us have heard stories of people who have household members, right, who are infected, but other people in the household don't get infected or don't get sick. They might have gotten infected, but they don't get sick. I think that's because immunity really is there. I always give the example, if we had 2 rooms of people, 100 people in each room, and half the people were fully vaccinated and one room was fully vaccinated and boosted, the other room was not. And you took COVID-19, Omicron, BA2, and you put it into the air conditioning system in both rooms. Much fewer people in the room who are vaccinated and boosted would come down with COVID, much fewer, even infection. So some would, but much fewer than the room where people are not vaccinated. So it does protect you. You're definitely going to be less likely to get it. So the timing is very hard. I once going beyond 6 months, I'm feeling like antsy that you may not be as protected against infection. Now, if you get it before June, chances are you'll be fine. So I don't think there's a wrong answer here. I think you could do it now, knowing that you might get another dose by the end of the year. If that's a big deal to you, then wait. But I don't think there's a bad decision here. But are you like me? Are you a crazy masker? Or are you, out there doing stuff and living your world, like it's over, then you might think about, well, now's the time to top it up. There's no wrong answer here.
somebody asked in the
Vaccine
chat.
boosted, masked in public.
Yeah, there you go.
Yeah, indoors. Let me be clear, indoors. Whole Foods, Weaver Street, Walmart, Home Depot, Lowe's, at work, I wear my masks. I love my mask. I wear my mask indoors. Outdoors, totally different ballgame unless someone's in your face. If someone's talking to you and they're really close to you outdoors is not going to protect you. So you should just be really clear. It's not like outdoors is like perfect, but it reduces the risk. But indoors, if we were in a room together right now, I would be masked, totally masked. So that's a problem, because if you'd like to eat in restaurants that have, only indoors, that's a problem. And that is not something that that I do yet. When will I do it? That's a good question. So I just showed you the numbers, 100 per 100,000 people. And that's an underestimate in Durham. I don't know what my magic number will be, but I could tell you, just ask yourselves, how many coworkers, neighbors, their kids, what kind of messages are you getting from Chapel Hill High, friends who are coming down with COVID-19? Over the last 3 weeks, it's been off the hook. I'm getting messages almost every day. When it starts to die down, when we start to get like 50 cases per 100,000, back to where we were last July, where we had those 2 weeks where everyone was getting together again. Like, I'm not there yet. The case numbers are going up. They're not going down. I don't want to get Omicron right now. I want to wait. And this is not such a big deal. So indoors, I think you're nuts not to wear this if you don't want to get COVID. If you're accepting the risk and you say, oh, I could get it, I'm vaccinated, nothing's going to happen, it's going to be fine. Totally okay, I get it. But I do this everywhere, indoors.
This is an incredibly silly question, but what are your guidelines for mask cleanliness? Like, I know in the beginning we were all, putting them in baggies and washing them obsessively. Yeah. I just don't know what.
All right, let's talk about masks. Okay, so baggies are actually not what you want. Like a paper bag is better. You want them to be dry and not wet, and you want them to just like be out in the free air. So surgical masks, you can wear this all day. These are just regular surgical masks. I like this one because the nose thing really sticks. It doesn't like flop. So regular surgical mask works really well. These things are no joke. They work well, but they don't work as well when there's a big gap, against your skin. So if I was just wearing it like this is pretty darn good because I've got a seal here, a seal here. I'm not wearing, like a helmet, but this really does cut down. What I like about the mask on top, a cloth mask on top, and this one's synthetic, which is fine, but on top is, once I cinch it, it really pushes down the seams on the side. And I like that. And it keeps my surgical mask in place. So I don't think it's anything magical about virus getting through this is going to be harder than getting through this. But it's the sides that really help, because I see people all the time where it's just like pleated. And it's just like air is getting right through there. And I just don't think that's as good. But the data show that, and I don't want to say this, I shouldn't say this, but data show that even like gaiters, they work. Some of the cloth masks don't work as well because they're poofy, but it all works. A bandana doesn't work, but like a gaiter covers your whole face. I wouldn't rely upon that. I really do like this. And you can play with the back thing so that it doesn't bother your ears. There's all sorts of things you can do. I'm a big fan. I'm seeing people right now in the hospital and I'm wearing this. And these are some of these people have, infections, and some of them have recent COVID. I'm wearing this.
And wash every day, wash every time.
No. So the cloth mask, I don't bother washing all the time. Like maybe once a week is what we do at home. We have cloth masks maybe once a week, but the surgical mask, I use a different one every day. Yeah, N95 you can use every day for a week.
Good to know. Thank you. Thank you for that. Any other questions at all? Otherwise, I know Dr. Wohl, you're very, very busy, so I don't want to keep you too much longer, but we really appreciate you taking the time. This is always so informative, and it's such an important topic, and we appreciate you sharing your expertise. So thank you for taking the time to be here with us today.
Anytime. Thank you.
Thanks.
Right,
That was
take
great.
care.
That was really good. Yay. And thank you all for being here too. You are all welcome to find complimentary resources on today's topics and our speakers' contact information to ask any other, about, contact information if you want to reach out. I will put, again, that link into the chat. You can always email one of us too if you have questions that you want to have us send on to the speaker. So I'll put that in. I also just wanted to let you all know about a new program we have coming up called Schmooze and Nosh. I don't know, it's hard for me to say that. We hope that you'll join us. We're launching it in May. It's a new social program for older adults. The first one's going to be May 25th from 2 to 4 here at the JCC. Join us. And as he just said, we'll keep it ventilated and maybe outdoors. Keep it safe. Join us for snacks, casual conversation activities. Details will be on the JCC website and through highlights. So we hope that you'll do that. You'll join us for that. And we also will be sending out next week when this conference is done. These videos will be up on our website so people can watch it. And also we'll be sending out an evaluation form so you can let us know about your thoughts about the program and the speakers. And if you could take the time to fill that out, it's very, very helpful for us to make improvements for next year. So thank you all for being here today. We hope you'll join us tomorrow. Tomorrow is going to be same time, 10:30 to noon. Make sure you RSVP, and the speaker is going to be Rebecca Grossfeld talking about movement for older adults. So we hope that you'll join us here. So have a great rest of your afternoon, everyone. Thank you.
Bye, everyone.